Welcome to this module on neurologic evaluation and workup in the urgent care. Let's get started. Welcome to the Master Course on Urgent Care, brought to you by Kruuse. If you're like me, neurology and neurologic cases are not always my favorite to tackle. Hopefully, this course will give you a step-by-step approach on how to examine neurologic patients so you can better localize their lesions and set them up for appropriate diagnostic workup and success in the hospital. Let's start with a slightly more detailed description of how to evaluate the neurologic system. Complete evaluation of the neurologic system includes evaluation of the following items: mentation, gait and posture, cranial nerve reflexes, segmental spinal reflexes, proprioceptive assessment, and spinal palpation starting at the cervical spine and working your way to the lumbosacral spine. It also includes evaluation of nociception, or the neural processes of encoding and processing noxious stimuli. First, let's talk about how we evaluate mentation. A patient's mentation, or level of alertness and responsiveness, is classified into the following categories: normal, usually described as bright alert and responsive or quiet alert and responsive in a hospital setting; mild, moderate, or severely obtunded, with obtundation meaning a decreased responsiveness to normal environmental stimuli; stuporous or semi-comatose, where the patient only responds to vigorous or noxious stimuli; and comatose, where the patient is not responsive to any stimulus, including noxious stimuli. Mentation can help us localize where lesions are. The brainstem contains the reticular activating system, which projects to the cerebrum, so a normal mentation requires a normal cerebrum and brainstem. Based on this, we can safely say the opposite of normal mentation implies either the cerebrum or brainstem is malfunctioning or not translating signals properly. Brainstem involvement usually equals cranial nerve deficits and mentation deficits. If no cranial nerve dysfunction is present, abnormal mentation is more likely the result of a lesion in the cerebrum or thalamus, located rostrally to the brainstem cranial nerve nuclei. Second, after mentation, we want to perform a gait and posture evaluation and assess whether the patient is ambulatory or non-ambulatory, has paresis or plegia, and if present, is it affecting one or multiple limbs? Is the patient circling, and if so, is it in one particular direction? And what is the posture positioning of the head? For example, is there a head tilt, a turn, or torticollis, where you have both a twist and a turn? Or does the patient have apostatonous positioning, meaning positioning with backward arching of the head, neck, and spine? We can use our gait and posture evaluation to localize lesions as follows. A head tilt is more consistent with vestibular disease. A head turn is most consistent with cerebral or thalamic or forebrain lesion on the ipsilateral, meaning same side as the head turn. Circling suggests cerebral disease, in which case the circling is toward the same side of the brain where the lesion is, or vestibular disease, where circling can be towards or away from the lesion, just to confuse us. Decerebrate posture, or extensor rigidity of the forelimbs and pelvic limbs, with head and neck extension, or apostatonous, suggests a severe midbrain lesion and indicates a poor to grave prognosis. Decerebellate posture, with forelimb extensor rigidity, head and neck extension, and tucking or flexion of the pelvic limbs, suggests a cerebellar lesion. This is not to be confused with Schiff-Sherrington positioning. In Schiff-Sherrington positioning, it's a marker of acute trauma to the spine at the level of the T3 to T7 thoracic vertebra. It's important to note that with Schiff-Sherrington positioning, it differs slightly from decerebellate, as you have head and neck extension and forelimb extensor rigidity, but you have flaccid paralysis of the pelvic limbs instead of flexion. Determining forelimb versus pelvic limb involvement also helps us to determine localization. If the thoracic and pelvic limbs are affected, then lesions can be localized to the brain, C1 to C5, or C6 to T2 spinal cord involvement, or generalized neuromuscular disease. If just the pelvic limbs are affected, lesions are typically caudal to the T2 vertebra, so the T3 to S2 spine is affected. It's also very important to delineate paresis versus weakness. Weakness implies an issue with the motor unit in the lower motor neuron cell body of the spinal cord, the peripheral nerve axon and/or the myelin, neuromuscular junctions, or the muscle itself. Paresis describes decreased voluntary movement and originates from either the upper motor neuron or lower motor neuron lesion. Third, we look at cranial nerve evaluation. Oftentimes, the tests for cranial nerve evaluation are pretty straightforward, but they can be more complicated tests to interpret. There are 12 main cranial nerves. The olfactory nerve, which isn't usually evaluated, the optic nerve, oculomotor nerve, trochlear nerve, trigeminal nerve, abducens nerve, facial nerve, vestibulocochlear nerve, glossopharyngeal nerve, vagus nerve, accessory nerve, also sometimes called the spinal nerve, and the hypoglossal nerve. Cranial nerve evaluation is performed by assessing the menace response, the pupillary light reflex, trigeminofacial reflexes, corneal reflexes, the absence or presence of physiologic nystagmus, and the presence or absence of a gag reflex. Each cranial nerve has an afferent, or moving towards the brain, and an efferent, or moving away from the brain, branch. For the purposes of this lecture, we will focus more on what cranial nerves are associated with each cranial nerve reflex, and we will not delve into which afferent or efferent branch is being affected. Menace response involves moving the hand quickly towards the eye on either side of the face without actually touching the face and without disturbing the vibrissae hairs or the whiskers. It involves recognition and processing in the cerebral cortex. Pupillary light reflex assesses midbrain function, particularly cranial nerve 2 and the parasympathetic limb of cranial nerve 3. This is accomplished by shining a bright pinpoint light into the pupil and watching for contraction or meiosis of the pupil. You want to shine the light into each eye individually to look for a direct PLR response, as well as assessing what the pupil is doing on the opposite eye to confirm the presence of an indirect PLR response. You should also evaluate for the presence of anisocoria, or pupils of different sizes at this time, as this can be helpful with lesion localization along the optic processing paths. Trigeminofacial reflexes involve evaluating for the palpebral response, meaning the eye blinks when you touch the inner or outer corner, the vibrissae response, meaning the lips move when you tickle the lip hairs, and the lip pinch, so you pinch the lip and the pet pulls it away. This assesses the pons by looking at cranial nerves 5 and cranial nerve 7. The corneal reflex also assesses the pons. This is performed by attempting to touch the eye and watching the eye blink and the globe retract at the same time. This assesses the ophthalmic branch of cranial nerve 5 and 6, with cranial nerve 6 being responsible for globe retraction and cranial nerve 7 being responsible for blink. Physiologic nystagmus is the normal rapid movement in the opposite direction of head turning that can be induced by moving the head up and down and side to side. It evaluates the pons and midbrain as well as cranial nerves 8, 3, 4, and 6. The presence or absence of a gag reflex evaluates the medulla and cranial nerves 9, 10, and 12. Localization of cranial nerve deficits usually supports an ipsilateral, meaning same side, lesion in the brainstem or peripheral cranial nerve. This means the lesion is on the same side as the deficit. The only variation to this is the Minnis response, which is frequently affected by lesions elsewhere in the brain and requires evaluation of other cranial nerve tests to determine whether afferent or efferent nerves are involved. Following cranial nerve evaluation, we will then assess our proprioceptive reflexes. This involves flipping each of the patient's feet over to the dorsal border, like this, and seeing if the patient correctly fixes their footing by flipping it back. Normal placement requires intact peripheral nerves and the spinal cord, brainstem, and cerebrum, so it is one of the least specific tests for diagnosing neurologic diseases, but it can give us a lot of information about the patient's mobility. Fifth, we'll look at segmental reflexes. Segmental reflexes are necessary for localizing spinal cord lesions and determining whether the upper motor neuron or lower motor neuron system is affected. They are broken down into thoracic limb reflexes, pelvic limb reflexes, and cutaneous trunci muscle reflexes. The thoracic limb reflexes assess the biceps and musculocutaneous nerve, the triceps and radial nerve, or main weight-bearing nerve, and flexion and withdrawal, which is mostly the musculocutaneous nerve. The pelvic limb reflexes look at the patellar reflex, which is an assessment of the femoral nerve and the L4 to L6 spinal cord segments, which are the main weight-bearing segments. The gastrocnemius reflex, which assesses the sciatic nerve at L6 to S1. The perennial reflex assesses the pudendal nerve at S1 to S3. And then last but not least, flexion and withdrawal, which is mostly the sciatic and some femoral nerve for the hip flexion. The last segmental reflex is the cutaneous trunci muscle reflex, which assesses T3 to L3 spinal nerves and cord and C8 to T1 spinal nerves. As stated, the segmental reflexes are necessary for localizing upper motor neuron versus lower motor neuron lesions. Upper motor neuron signs include normal to increased reflexes, normal to increased muscle tone, muscle atrophy, which occurs over a period of weeks to months due to lack of use, paresis and paralysis, and proprioceptive placing deficits. Lower motor neuron signs include decreased to absent reflexes, decreased to absent tone, muscle atrophy occurring over a period of weeks to months, this time secondary to denervation, paresis or paralysis, and proprioceptive placing deficits. The presence of upper motor neuron versus lower motor neuron signs is essential for spinal cord lesion localization. In C1 to C5 myelopathies, patients have ipsilateral upper motor neuron signs in the thoracic and pelvic limbs. In C6 to T2 myelopathies, patients exhibit ipsilateral lower motor neuron signs to the thoracic limbs and upper motor neuron signs to the pelvic limbs. With a T3 to L3 myelopathy, a patient will have normal thoracic limbs, ipsilateral upper motor neuron signs to the pelvic limbs. In a L4 and caudal myelopathy, so L4 and down the spinal cord, patients have normal thoracic limbs, ipsilateral lower motor neuron signs to the pelvic limbs. Management concerns for the myelopathy patient include recumbent care, so making sure that we're turning them and that they're not getting bed sores or soiled. Bladder management because they may have increased urinary bladder urethral sphincter tone or flaccid bladder paralysis, therefore urinary catheterization may be necessary. And patients with myelopathy are also at an increased risk for muscle atrophy. Therefore, passive range of motion and physical therapy can be extremely helpful for maintaining muscle tone in these patients. These patients are also at an increased risk for aspiration pneumonia, so careful respiratory monitoring is indicated. If you're concerned at all that the respiratory rate or effort is increasing, check some chest x-rays to make sure they haven't aspirated. Sixth, on our neurologic examination journey is sensation and nociception evaluation. Superficial pain perception is evaluated through application of noxious stimuli applied to the interdigital skin. You should look for a conscious reaction like whining or crying and attempting to bite or escape from you. Deep pain perception is evaluated by application of noxious stimuli to the digit itself with the goal to stimulate the actual bone. There should be a conscious reaction here as well. It is very important to note here that the deep pain reflex is different than the withdrawal reflex. A patient can have a withdrawal without being deep pain positive, as this is a non-conscious reflex at the level of the musculocutaneous nerve. However, you cannot have deep pain without a withdrawal reflex. Loss of pain perception, particularly deep pain, is strongly associated with a poor prognosis for recovery of function. You can also use the modified Glasgow Coma Scale, a scoring system evaluating motor activity, brainstem reflexes, and level of consciousness on a score of 1 to 6. With a higher score associated with a more normal examination. Let's take this information and do a little bit of practical application. Consider this. An owner presents their 14-year-old female spayed collie mix to you one evening. The dog has a recent history of polydipsia and inappropriate urination in the house. She also has just seemed off for the last 2 weeks. She walks into rooms and seems to stare off into space, forgetting why she's there. She also nipped at the owner yesterday, which is very unlike her. This morning, around 5 a.m., the owner heard thrashing and clanging at the side of the bed and woke up to the dog having a seizure. The seizure was tonic-clonic and the dog urinated and defecated on themselves. Since then, the dog has been dull and depressed, unsteady on her feet, and she is circling to the right side and falling to the right. On presentation to your hospital, the dog is dull and depressed with a heart rate of 60 beats per minute, a blood pressure of 140 millimeters of mercury, and normal respirations. You perform a neurological examination confirming a right-sided head turn, right forelimb and hind limb proprioceptive deficits, absent menace on the right side, and otherwise normal cranial nerves. Based on this presentation, what is your lesion localization for this dog? Your options are left-sided brainstem lesion, left-sided forebrain lesion, right-sided brainstem lesion, and right-sided forebrain lesion. Take a minute to decide. If you guessed right-sided forebrain lesion, you would be correct. Let's try a slightly different one. You get a phone call from a very upset owner that their dog has just been hit by a car and can't walk. On presentation, the dog is laterally recumbent with head and neck extension, forelimb extension and rigidity, and a tucked posture in the pelvic limbs. The dog appears to be very painful and vocalizes on manipulation of his body, particularly around his mid-spine. You perform a brief physical exam and neurologic examination prior to giving him pain medications to help with your localization. You note that the tucking of the hind limbs is actually flaccid paralysis of the pelvic limbs, and that his cutaneous trunci reflex stops at the level of L4. What is the next diagnostic step that you could take in this dog, and what might you expect to see on that diagnostic? Check your screen for a couple of options. If you said, let's take a lateral spinal radiograph, and you might expect to see a displaced spinal fracture with spinal cord compression at the level of T3 to T7, you'd be right on point. When working up a neurologic patient, routine diagnostics, including complete blood count, complete chemistry panel, electrolyte evaluation, and venous blood gas, should be pursued. The blood gas evaluation is especially important, and I encourage you to take that step if you have the capacity to get a blood gas in your practice, particularly if you can get an arterial sample, as it provides you with an arterial carbon dioxide reading that can inform you about the absence or presence of respiratory compromise in your patient that you can see secondary to head trauma. Marked elevation in carbon dioxide or hypercapnia associated with hypoventilation or decreased breathing can cause cerebral vasodilation and increase intracranial blood flow and cerebral edema. On the opposite side, hyperventilation leading to low CO2 can cause vasoconstriction and decreased blood flow to the brain. This can be therapeutic for short periods of time, but ultimately exacerbates ischemia and tissue damage in the brain. Additionally, if a patient is presenting for trauma or suspected central brain lesion and neoplasia, Thoracic radiographs and abdominal ultrasound should also be performed to rule out intrathoracic and intra-abdominal organ injury and neoplasia. Last but not least, the gold standard workup for any patient with neurologic deficits is an MRI. Referral to a neurologist or, if available, in-house neurology consultation is strongly recommended in any patient with neurologic deficits. This is going to give the patient and the owners the best chance of success in managing their patient and getting them through this crisis period. This concludes our module on neurologic evaluation and workup in the urgent care. I hope this module has given you a helpful review of emergency neurologic examination in the urgent care setting and a couple of case examples of what you might see come through the door. Now please proceed to the next module when you're ready. Thanks!